All right, let's go ahead and get started. I'm going to talk about kind of benign liver anatomy, physiology, and a little bit of pathology. Thanks to Cameron, his third year, for making this. No sense in reinventing the wheel. So a little bit about history. So first described surface details as early as 2000 BC. It's 1654 where Francis Glisson is the first one to describe some of the seriousness of injuries and the anatomy of the blood vessels of the liver accurately. The first partial resection happens in 1716. Mr. Pringle there describes the compression of the portal triad in order to control some of the surgical bleeding. In 1908, you get the first anatomic resection in 1952, and then you get the segmental anatomy described by Quinaud in 1957, and then intraoperative mortality, which previously exceeded up to 20% in the 1980s, significantly decreases as we become more adept in the knowledge of the anatomy of the liver as well as in some of our anesthesia techniques. So surface anatomy. So the liver goes up as high as the fifth rib on the right and the sixth on the left. Obviously, you never want to put a chest tube into the liver, so that's why we go fifth intercostal space or fourth intercostal space, level of the nipple line, and then obviously put your finger in there and feel before you go jamming anything in there. Again, the whole thoraco-abdominal box, this is why this is so important, because a gunshot wound or penetrating trauma to the chest doesn't necessarily mean that it's in just the chest. It could have an injury to the abdomen or structures therein. So gross anatomy, when you're looking at the liver, this is what you're seeing. This is obviously a broken down picture of it. So when you look at the posterior aspect, you've got the left and middle hepatic veins, which drain into the IVC, as well as the right, which drains into the IVC. You've got a bare area on the back side of the liver. This has to do with its embryology, and it doesn't form a peritoneal surface. It's not covered by Glisson's capsule. You have a left lobe, obviously, and a right lobe. You can tell that the right lobe is considerably larger than the left, and therefore the majority of the pathology and the blood flow kind of goes to that side. That kind of becomes important, I guess, a little bit later on when you're talking about resections, functional liver remnants, etc. Traditionally, the falciform was, you're looking in the abdomen, you see the falciform, you're like, oh, that'll divide, left and right, but it really has no functional significance in terms of defining the anatomy of the liver. I don't really think this stuff is that important, the embryology of it. It may show up on a test somewhere. If you want to be a liver surgeon, then maybe that helps as well, but you can kind of go through this portion on your own. Just know that it begins as endodermal epithelial outpouching. You have the ligamentum teres, which is the inferior edge of the falciform. This becomes the remnant of the umbilical vein. This can be significant when you're doing surgery and you're taking down the falciform. If someone's got portal hypertension, they can get recannulation of this. So it can bleed. It can be something good to know about. And it's a fairly common PIM question as well. The vitelline veins become the portal system. And then there's an important role in hematopoiesis. It's the main site between months 2 and 7 of gestation. This is a good kind of graph that shows you as you get older in your gestational period which areas of your body are functioning as your primary hematopoiesis. So you can see it starts off as the yolk sac, and then it primarily becomes the liver, a little bit of the spleen, and then the bone marrow takes over. So Cam likes to pimp in his lectures, so he asks, what's Candle's line and what are Quinaud's segments? Candle's line, so this is actually what defines your left and your right lobe of the liver. This is if you were to draw a line from the IVC down the gallbladder fossa. And then you have Quinaud's segments, which are each segment of the liver, 1 through 8, and they are each fed by their own portal pedicle, which consists of a portal vein, an hepatic artery, and a bile duct. So these are the segments. Left is 2, 3, and 4. Lateral would be 2 and 3. Medial would be 4A, 4B. These are fed by the left portal pedicle. The left portal pedicle generally will have a little bit longer of a distance that it travels before diving into the liver parenchyma, versus the right will be a little bit shorter. The right segments are 5 through 8. Anterior would be 5 and 8, and 6 and 7 are fed by the right portal pedicle. This is kind of when you're looking at a cross-sectional image, what you're looking at. Get a little bit farther down. The caudate lobe is a little bit unique. It's fed by both the right and the left. It has branches also that go right to the IVC. You can actually get a complete 360-degree involvement of the caudate lobe around the IVC at times. So this is important when you're doing liver transplants or partial liver resections, as you can get into some significant bleeding. I think this is pretty helpful. I always do this when I get a little confused or I need to kind of remember what segment is what. If you kind of tilt your hand where you're kind of looking at your kind of thumb and index finger towards you on your right hand, then you'll kind of know actually how it lies in the abdomen when you're looking at it. So the portal vein, brings 75% of the deoxygenated blood to the liver. It actually still provides about 70% of the oxygenation to the liver. It's made up when you have the SMV that combines with the splenic vein, and then you get your portal vein. It's obviously part of your portal triad. It sits in your hepatoduodenal ligament. This is what I just mentioned. You can measure the pressure in the portal system because there are no valves. So by putting a catheter down in there, you can obtain the pressure. Normal is going to be less than about 5. If it's greater than 10, you have significant portal hypertension. And I think there's another liver lecture regarding portal hypertension a little bit later on. Okay, so this is kind of some of the little bit more interesting, I think more relevant stuff, because a variety of surgeries are going to rely on your knowledge of, the arterial supply to not just the liver, but the celiac trunk. You'll see aberrant stuff during bariatric surgery or Nissen fundoplications, and then obviously during Whipples, it's imperative to know the anatomy and the possibilities of the different places where the arteries can originate from. So this is just your normal anatomy. You've got your celiac trunk, which obviously gives off your splenic, your common hepatic, and your left gastric. Your common then becomes your proper hepatic after the point in which the GDA comes off. Then you have your supraduodenal and your right gastric artery as well. And then branches into right and left hepatic arteries, and then your cystic artery, more often than not, coming off of your right hepatic artery. So this brings about 25% of blood flow to the liver. It's about 30 to 50% of its oxygenation. The anatomy is really only normal, quote unquote, in about 60% of the time. Most commonly, you're going to have a replaced right hepatic, and there's about a lot of different places where it can be replaced off of. And you can have a replaced left about 3 to 10% of the time. So if you're talking about a replaced right, this is the hepatic artery, the right hepatic artery taking off from the SMA. This is probably the most common one. I've seen this several times, and it's good to look at your imaging before going in just to make sure that you don't have any aberrant anatomy that you need to be aware of. They talk about being able to feel a pulse lateral to your common bile duct when you're doing a dissection, common bile duct exploration, or whatever it may be you're doing. And if you have a pulse lateral, then you may have a replaced right or an aberrant right hepatic artery. You can have a replaced common hepatic, taking origin from the SMA as well. You can have a proximal right and left bifurcation. You can have a replaced left hepatic originating from the left gastric. You see this when you come through your pars flaccida and your lesser omentum, and there's a large vessel going right to the left lobe of the liver when you're trying to get access to your esophagus and your hiatus, esophageal hiatus. And sometimes you have to take it, and sometimes you can avoid it. You can have accessory, so obviously the difference between accessory and a replaced. Replaced is you still have just one, but it's coming off of a different area. Accessory is you have an accessory one, meaning another one, as well as the original one. So this is an accessory right coming off of SMA. This is an accessory left coming off of the left gastric. You can have an accessory left hepatic from the right hepatic. You can have a right hepatic that goes anterior to your hepatic duct. You'll see this sometime when you're doing Whipples and doing your reconstruction for your hepatico J. So when you're talking about the biliary anatomy, you can have left and right hepatic ducts that drain their respective liver segments, comes down. The caudate has its own drainage, usually through right and left systems. In about 15%, it's only through the left and 5% through the right. Common bile duct's about 10 to 15 centimeters long. Normal is about 6 millimeters in diameter. It can get bigger. Usually we say about a millimeter per decade for every decade over about 60. So, an 80-year-old, maybe 8 millimeters is normal. Gallbladder lies up against the segments 4 and 5, and then there can be a significant amount of variations, obviously, of the gallbladder and the biliary tree as well, and these are good ones to know. So variations in the cystic artery, A there is the most common. You can see it coming off in the triangle of Callot, and then you can have a variety of other cystic arteries locations, obviously, coming off of SMA, coming off of your celiac, coming off of your left, etc. You can have biliary anatomy. I think it's every general surgeon's dream to get in there and see a double gallbladder. It's like a double rainbow or whatever that video was. It'd be pretty sweet. I've seen a left-sided gallbladder before. But again, these have a pretty wide variety of variation, but it's a lot rarer than your vascular variations. The bile duct confluence variation, so you can have a variety of these as well. Again, you're going to want to take a good look at it before you're going into your surgery if you're doing a Whipple or if you're doing any kind of, you nicked your bile duct and you have to go do a Hepatico J. Just note there's a lot of variations and you should tease it out before you go making any big moves. So what's the blood supply to the common bile duct? You have your 3 o'clock and your 9 o'clock artery. These come off of proper hepatic and your right hepatic. These travel down their respective time clock face sides, and that's why when you do your choledochotomy, generally you want to be on the anterior surface, as these are going to be avoiding the arteries that supply it. And it has other pretty well supplied blood supply from collaterals to the common hepatic, the GDA, and the retroduodenal arteries. Alright, so functional unit of the liver is an acinus or a lobule. You have your inflow, which is to your interlobular artery. This is from your hepatic artery, and then your vein from your portal, and then this goes into sinusoids lined by hepatocytes, and then your outflow is through that central vein into the hepatic veins. So the cells that make up the liver, 60% of the mass of the liver is going to be hepatocytes. Super huge variety of functions for the liver, extremely important, obviously. I think it goes without saying. Uptake, storage, release of nutrients, gluconeogenesis, glycogenolysis, fatty acid, lipid, plasma protein synthesis, the production and the secretion of bile, and as well as the degradation of toxins. So it's approximately 4% of your total body mass. It consumes almost 30% of your total body blood flow, 20% of the total oxygen, and 20% of the total body caloric intake. The blood flow increases after ingestion and decreases with exercise for sympathetic stimulation. And then you get on average about 1.5 liters of bile secretion per day. 80% of that volume is produced by hepatocytes, 20% from the cells actually lining the bile ducts further down. So the enterohepatic circulation is pretty unique. It actually is able to extract about 90% of the bile salts that you pass into your GI tract. You can reabsorb through this circulation. You've got primary and secondary. So primary bile salts are cholic and chenodeoxycholic. These get excreted and processed by bacteria in the GI tract, and then they get broken down into your secondary bile salts, which are your deoxycholic and your lithocholic acid. So breakdown of bilirubin. So bilirubin binds to albumin in blood. This is why you can get like a haptoglobin level, which will tell you the amount of non-broken down or freely secreting, or excuse me, circulating. You have it's internalized into hepatocytes, so conjugated and then secreted within the bile. You get deconjugation of this into the urobilinogen in the GI tract and reabsorbed with bile, and then some urobilinogen is reabsorbed and secreted in urine. So the liver is the major site of storage and distributor of glucose. It's stored as glycogen. Only the liver can break down the glycogen to use glucose for other cells of the body. The skeletal muscle can also store glycogen and break it down, but it uses it for itself. Excess carbohydrate is converted to fatty acids and stored in the adipose. After about 48 hours, your glycogen storages get depleted and you turn to gluconeogenesis. The substrate for gluconeogenesis is mostly from amino acids. I think it's alanine from muscle breakdown and glycerol from triacylglyceride breakdowns. Lipid metabolism, so fatty acids are made in the liver when you have excess glucose. During lipolysis, free fatty acids are broken down in the liver. Beta oxidation is going to yield ATP and ketone bodies. In a fed state, your free fatty acids undergo esterification with glycerol to form triacylglycerides. This is then in a fed state, you get beta oxidation, which is in a starved state. Increased amount of fatty acids in the liver can lead to steatosis and eventually steatohepatitis. Protein metabolism, so amino acids not used in the peripheral tissues are managed by the liver. They can't catabolize branched chain amino acids, so leucine, isoleucine, and valine. It is the key site of production of many of your key proteins, from ceruloplasmin to iron storage binding proteins, alpha-1 antitrypsin, albumin, and then all of your coagulation factors except for factor VIII. And then metabolism of fat-soluble vitamins, so A, D, E, and K. It's the sole storage site of vitamin A. I think there's a question out there somewhere I've seen, like what happens when you eat a bear's liver. They have like an insane amount of vitamin A, so you can get vitamin A toxicity. Vitamin D is activated one step in the liver and then another in the lungs. K is critical for the coagulation factors obviously made in the liver. When you're talking about metabolism of drugs and toxins, you've got phase 1 and phase 2. Phase 1 is oxidation, reduction, and hydrolysis. This makes compounds that can actually be more potent. But phase 2 is a transferase reaction, which makes them inactive or less active. All right, so this is kind of a little bit more of the meat and potatoes, things that we actually deal with. So assessment of liver function. So you've got a variety of LFTs that we order, alk-phos, ALT, AST, bilirubin, your transaminases. These are your most common markers for hepatocyte injury or hepatonecrosis. AST can be found in other organs. ALT is specific to the liver. They're not very specific and they provide little prognostic value, but they can at least give you an idea of what's going on potentially. Alkaline phosphatase is made in the liver. It's also made by the bile ducts and bone, intestine, placenta, kidney. GGT is made in the liver, spleen, kidney, pancreas, heart, and brain. You've got your albumin, so it's not as sensitive to evaluate for liver function. The most specific test to evaluate for synthetic function of the liver, I think, is going to be your INR, and those will be your clotting factors. So what quantitative tests? It's not clearly better than scoring scales or clinical observation. There's an aminopyrine breath test. It's measuring radiolabeled CO2 after administering radiolabeled aminopyridine. I've never actually seen this used. I don't really think it's of any really clinical value. So your Child's Pugh classification, this takes into account bilirubin, albumin, your prothrombin time, your ascites, and your encephalopathy. And Child's Pugh score was developed by, I think, Childs, Turcott, and Pugh. Somehow they always leave out that one guy. And it's usually used for cirrhotic patients who are going to require some form of liver surgery. It can kind of indicate to you the mortality to be expected and survival rates after hepatectomy. So here's your operative mortality for major abdominal surgery for A, B, and C. You can see obviously A's are still appropriate to operate on, but B and C are pretty much no-goes, barring some, catastrophe, and even so, we probably send them to a center of excellence like the Ohio State. All right, so infectious diseases of the liver. This stuff's pretty interesting, and it's commonly tested on both in mock oral situations and on the ab site. So pyogenic abscesses, It's about 22 of 100,000 hospital admissions. The liver is exposed regularly to bacterial load through the portal system. The portal system drains your GI tract and then brings it through the liver. You also have direct extension from your biliary tree. So initially, before we had earlier diagnosis of appendicitis and diverticulitis, you were seeing more pyogenic abscesses related to that. Now it's probably more common that they're coming direct extension from cholangitis or ascending cholangitis, causing pyogenic abscesses within the liver. So where do they show up? Again, the majority of the blood goes to the right liver. The right liver is much larger, so 75% of these are in the right, 20 in the left, and rarely in the caudate. Sometimes they're bilateral. 50% of them are solitary. They can be multiloculated or single cavity. Common organisms include E. coli, Klebsiella pneumonia, staph, Enterococcus, strep viridans, and Bacteroides. Klebsiella can be gas-forming. It's rare to see Pseudomonas, Proteus, Enterobacter, Citrobacter, Serratia. Just think kind of what are the bugs that you're going to see most commonly in your biliary system. So how do they present? So generally they're going to be jaundice, right upper quadrant pain, and tendinous palpation. Well, that's what the book says, but really it's only present in about 10% of patients. The majority of these are going to have nonspecific vague abdominal pain, fevers, chills, weight loss, cough. You're going to see a leukocytosis in 90% of patients. They'll have elevated LFTs and maybe even elevated bilirubins. Occasionally, you can see a mass in the right upper quadrant on X-ray. Obviously, nowadays, most people are going to have a CT by the time we are on board for anything related to a pyogenic abscess. And it's got really good sensitivity of 95 to 100%. So here you can see this kind of thing underneath the liver that kind of looks like a gastric bubble on the wrong side. You can get colon that sneaks up there, obviously, as well. But this is an example of what a pyogenic abscess may look like under the right diaphragm there. So you obviously need to differentiate this between your hydididid or echinococcal and amoebic cysts because the management is going to be quite different. How do we manage pyogenic abscesses? The same way we would manage kind of abscesses anywhere else. So IV antibiotics, percutaneous drainage, and then tincture of thyme. If it doesn't get better, then they may need some further procedure. But again, historically, mortality was almost 100% before the introduction of IV antibiotics. From 1945 to the 80s, it got better, 50%, and now its mortality is down to around 10% with some recent studies, I think out of Memorial Sloan Kettering, showing of about 3% mortality associated with these. So this is kind of a good table that differentiates amoebic versus pyogenic abscesses. I think your classic amoebic abscess patient is going to be 20 to 40 Hispanic or from South or Central America. They've got recent travel, drinking salt water, and they're almost always going to be men. 10 to 1 ratio for amoebic abscesses. And then you have serologic testing that you can do if you're really not sure before sticking a needle in it, and you can potentially see your positive serologies for your amoebic abscess. So what is, like I mentioned earlier, who's getting these amoebic abscesses? It's largely in tropical and developing nations. It's Entamoeba histolytica. There is another one, Entamoeba, that is benign and associated with diarrhea that does not cause these abscesses. It is endemic to Mexico, India, Africa, Central and South America. It's estimated by the World Health Organization that about 40 to 100,000 deaths per year. 55% of these are in endemic regions that have GI infections. And then, like I mentioned earlier, males are at a 10 times greater risk than females. So these cysts are transmitted fecal-oral route. Trophozoites released in the colon. It invades through the mucosa into the blood vessels there and then travels through the portal system up into the liver. So you may see a leukocytosis. It's not bacterial, and so you may not get the same degree of leukocytosis that you would expect with a pyogenic abscess. Your LFTs and your bilis may be also slightly elevated. Most common lab that's abnormal is going to be actually your INR. 70% of these will not have the amoeba in the stool, and you need to check serum anti-amoebic antibodies, which will be present in about 90 to 95% of people. You've seen acute infection, which implies that they've had this for less than 10 days. They'll have high fevers, multiple lesions, maybe more pain. Chronic is greater than 2 weeks with some vaguer symptoms, and then usually just a single right-sided lesion. Here's your imaging. You can see a nice hyperechoic rim, non-loculated, rounded lesion, and it's usually abutting the capsule. The stuff that the protozoa make end up kind of causing this necrosis, liquefaction necrosis within the abscess, but glycin's capsule is actually kind of immune to that, so it'll kind of break down the liver around it, work its way towards the periphery of the liver, and then it'll kind of stay there. So you'll see them at the edges of the liver. So you treat amoebic abscesses with flagyl. It can be curative in about 90% of them. You do worry about rupture, sudden abdominal pain, peritonitis, and then the overall mortality rate for all of these is about 5%. But if you ruptures, you can have a significant increase of mortality up to about 50%. So hydatid cysts, which is synonymous with echinococcal cysts, these are the kind of ones that they start, a definitive host is really dogs, and then an intermediate host is sheep, but we're also actually an intermediate host. You get the cyst in the larval stage. There are 3 common species of these. The Echinococcus granulosus is the most common, and then you can also see Multilocularis and Ligartus. It's pretty disgusting how it ends up in our body and what it does there. A parasitic embryo releases an oncosphere through the duodenal mucosa into the bloodstream. This reaches the liver or the lung or the brain, and then it implants and develops a larval stage, which is the cyst. And then 3 weeks after that, you get a visible cyst developing. It's got a 2-layered cyst wall. It's derived from its host tissues. The dead cysts and degraded capsules form a sand, and then you can even have daughter cysts, which can form, and then again 75% in the right lobe of the liver. So this can cause anaphylaxis. So this is what looks way different on ultrasound and on CT than your amoebic or your pyogenic. But again, if you have any concern, you need to rule it out prior. You can get serologic studies. Just brain echinococcus, that sounds terrible. And these require a little bit more in-depth treatment. So there's the surgical management. So obviously you want anesthesia to be prepared for any kind of anaphylaxis that may occur if you are to get some spillage of the contents. So have some steroids and some epi available. You want to pack off and drape the field before you excise the cyst in case you do spill it. And then you can aspirate it and then inject hypertonic saline or I think alcohol. And you unroof the cyst, and then you can either excise it, you can do a little resection, a wedge, a anatomic, you can marsupialize it, and then you may get about a 1 to 20% recurrence, usually less than 5%. You can't percutaneous drain this. This was previously contraindicated, but now they have, I think it's called PAIR. So percutaneous drainage, aspiration, injection, and then re-aspiration. So you're aspirating it out, and then you're injecting this salicylicidal agent, so 20% saline, 95% ethyl alcohol, betadine, hydrogen peroxide, and then you kind of swash that around, and then you re-aspirate it. They talked about this recurrent pyogenic cholangitis. I guess it's something to know about. It's found almost exclusively in Asians. They don't really know what causes it. Maybe it's strictures in the biliary system that's either caused by stones, or the stones are there because of the strictures. It's kind of chicken or the egg. And it can be associated with Clonorchis sinensis and Ascaris lumbricoides. So this is going to be your young Asian, lower socioeconomic background. They are at an increased risk for cholangiocarcinoma. Other complications can be choledochoduodenal fistulas, pancreatitis, duct obstructions. Most of these improve with conservative management. So surgical management, however, would include a common bile duct exploration, ERCPs, percutaneous transhepatic cholangioscopic lithotripsy. Pretty much what you're trying to do is decompress the duct, get rid of any stones, and then potentially bypass around any strictures if you need to. Okay, so that does it for benign liver. Kind of a quick talk for a long chapter. There's obviously a lot more details in the chapter, which I encourage you to supplement your reading with.